Hi all, so now we're going to talk about ultrasound guided paracentesis. So this is part of an overall larger lecture about ultrasound guided procedures. So why do we use ultrasound? We want to be able to visualize the procedure in real time. We can decrease the number of attempts, we can decrease the complications, and overall that leads to improved patient safety. So right now we're going to talk about paracentesis. So, why do we do paracentesis? So, some of the clinical indications for paracentesis in general are going to be new or undifferentiated ascites or known ascites with fever, abdominal pain, or altered mental status when you're doing a workup for spontaneous bacterial peritonitis or a symptomatic treatment of large volume ascites. Some contraindications to ultrasound guided paracentesis or paracentesis in general are going to be a coagulopathy, a surgical abdomen, or overlying skin infection. So, how do we do an ultrasound guided paracentesis? It's step by step. I'm going to use the ultrasound to scan for an ideal fluid pocket. So, I'm looking for the largest fluid pocket available in an ideal space away from the liver and spleen. And then I'm going to prep the patient for a sterile procedure. I want to think about how many liters I might be taking off, or if I'm just doing a diagnostic paracentesis and taking off a small amount. Then I'm going to either need my thoracentesis kit, or I'm going to use a spinal needle and a long angiocath and a 60 cc syringe for my diagnostic paracentesis. I do want to have the patient empty their bladder as well before I perform the procedure. And then I'm going to perform the procedure and send the sample of fluid to the lab for analysis. So when I go to do this procedure, I want to first decide, am I doing a diagnostic paracentesis and trying to send a little bit of fluid to the lab to identify maybe underlying infection or potentially help me identify the cause of ascites? Or am I doing a therapeutic paracentesis and the patient has liters of fluid in their abdomen and I'm just trying to help them feel more comfortable? So each one is a little bit different. When you do large volume paracentesis, you need to think about how much fluid you might be draining off and whether you'll use albumin or not if there's a need, and that's a different lecture for a different day. But so if you're going to do a large volume paracentesis, then I need the 1 liter vacuum bottles, which are going to hold the fluid you're taking off, and I need a thoracentesis kit, or I'm doing a diagnostic paracentesis and only taking really about 60 to 120 cc's of fluid to send to the lab. And then I'm going to use a 60 cc syringe, maybe a longer spinal needle or angiocath. I want to numb the patient with lidocaine. I want betadine. I want sterile gloves and a drape and a sterile ultrasound cover to perform this procedure. And then get a 4x4 gauze and Band-Aid. So when I first go to pick a pocket, I'm going to have the patient lie on their back, slightly recumbent. They can be sitting up at an angle, almost like they're in a beach chair. I'm going to scan the right and the left lower quadrant about 3 centimeters below the umbilicus. I also want to make sure that I'm paying special attention to the skin and soft tissue as to avoid any puncture of the inferior epigastric arteries or any engorged superficial veins. Then I'm going to mark with a sterile pen, or I'm going to put on my ultrasound probe, that sterile ultrasound probe, in order to do it truly ultrasound guided. So getting started, we're looking here with ultrasound in real time. We have sterile gloves on, so we're looking at, you can see that pocket right there. So we see a bowel just floating in a large anechoic fluid collection. We want to assess the pocket, the best pocket below the umbilicus with ultrasound. We're going to make sure that we are not above the umbilicus because we want to make sure we avoid the spleen and the liver. So picking a pocket, here we're seeing free fluid, but I'm also seeing the liver and the liver tips. So that's not going to be a great area. We definitely do not want to do a liver biopsy. We want to make sure that we are far away from the liver and far away from the spleen. So this is going to be a much better choice. We're seeing a nice large pocket of fluid. We are below the umbilicus. We are have emptied the patient's bladder. We are not seeing the bladder here, so this will be a very good pocket. The technique that we're going to use is called a Z-line technique, and so what we can do is we can pull the patient's skin taut, we can insert the angiocath, and when the tip is in the subcutaneous tissue, then we can release the skin, and it should essentially move the needle tip over about a centimeter and then go ahead and go into the peritoneal cavity. And this creates a Z-line or a Z technique, which should create a self-sealing skin tract to help stop leakage of the ascites or acidic fluid after the procedure. So right now we are using an ultrasound guided procedure, ultrasound guided paracentesis, sterile gloves, sterile drape, sterile probe cover. So identifying the pocket, which we are seeing on the screen behind us, we are going, so we're ready, syringe attached to the needle, we're going into the skin. Slowly, we should be moving the needle tip over about a centimeter if we can. It might be a little hard to appreciate here before we go in the rest of the way. So right now, we are now in the peritoneal cavity, and we are withdrawing our yellow ascites or acidic fluid, and we can actually put the angiocath in and then continue to withdraw any fluid here. So once we go in with the angiocath thoracentesis needle, if you want to do a large volume paracentesis, we can leave the catheter in the peritoneal cavity and hook tubing up to vacutainers, and then allow the fluid to drain. If I'm doing a diagnostic, I might just remove 60 to 120 cc's in order to send to the lab. And that concludes our lecture on ultrasound guided paracentesis. If you have any questions, please email me. Talk to you soon.